Hello everyone. So, I am here with a new lecture of antileprotic agents. In this we will discuss about what is leprosy, what are the types of leprosy and how we are treating the patients of leprosy. Yes. So, we will start with this leprosy. Leprosy is one of the infectious disease which is affecting the skin or nerves. Yes. It is caused by the bacillus. This is also one of the bacteria, Mycobacterium leprae. Yes, this is one of the chronic disease in which the skin or nerves is deeply impacted. Yes, Mycobacterium leprae multiplies slowly, therefore it is taking lot of time, and incubation period for the disease is going from average to the average, if we will see, it is 5 years. Okay, so it is a long time. Now, what are the symptoms of this disease? So, the symptoms are the skin lesions. Yes, there will be very severe skin lesions and it is very painful. Symptoms that may occur within 1 year, but it can also take more than this time. Yes, this disease affects the skin area or the nerve area, mucosa of the upper respiratory tract or the eye area. Yes, this is curable with MDR. MDT, multi-drug therapy. Yes. So, we will see what are the drugs under this. Before this, there is some data with the leprosy. Leprosy is likely transmitted via droplets. Yes, from the nose or the mouth during close contact with the person which is affected with this leprosy. Now, untreated leprosy can cause permanent damage or progressive damage to the skin area, nerve area, limbs or the eyes. Now, what is the number? If we will see the number, there were nearly this numbers, nearly 2 lakh new leprosy cases registered globally in 2018, according to official figures from 159 countries. Yes, from the 6 World Health Organization regions, based on nearly 1,84,000 cases at the end of 2018. Yes, prevalence rate, if we will see, means the number of cases per 10,000, here it is 0.2. Now, what are the drugs under this? So, see, sulfone, first category. Under this sulfone we have Depsone, which is donated as DDS. Then phenazine derivative, phenazine is one of the dye. So, clopazine under this. Yes. Then third, anti-tubercular drugs, rifampicine and etheonamide, they have also effect on the Mycobacterium leprae. There are some other antibiotics like ofloxacin, minocycline and claritomycin. They are prescribed when the disease is not going to show any effect by treatment of these of the drugs. Okay, at that time we can go for other antibiotics. Some of the clinical trials are showing that these drugs have effect in the this disease. Yes, they are effective. Now, we will start with the Depsone under the sulfone. So, Depsone is a diamino diphenyl sulfone. This is one of the cheapest, most active, commonly used member of its class. Now, how it is showing its effect? So, it is acting on the PABA. Okay. It is the leprostatic drug at low concentration. Yes, and if we will increase the dose, it will act as lepricidal. Yes. So, it will kill the bacteria also. Now, see this chart here. This diagram is showing how the Depsone is working. So, with the dietary folate, we will see the PABA, this para-aminobenzoic acid, is converted into dihydropteroic acid by the enzyme of dihydropteroid synthase. Okay. Now, dihydropteroid acid is converted into dihydrofolic acid. Okay. Dihydrofolic acid required one enzyme, dihydrofolate reductase, and then it is converted to tetrahydrofolic acid. This tetrahydrofolic acid is the active form of folic acid. Okay, so whatever the functions we are seeing with the folic acid, it is by the tetrahydrofolic acid. Yes. Now there are two classes of drugs which we can see. One is the sulfonamides. Okay, sulfonamides are acting on this area, this part, dihydropteroid synthesis. This will inhibit this enzyme. So what will happen? The conversion from PABA to dihydropteroic acid will not happen. Okay. There is another drug also, trimethoprim, which is working on dihydrofolic to tetrahydrofolic acid synthesis on this pathway. Okay. So what is important here is the step. Okay. So Depsone is also working on this step. Okay. It will affect on this PABA to the conversion of PABA to dihydropteroic acid. Now see the resistance of this Depsone. So Depsone resistance among Mycobacterium leprae was noted first seen in the 1964. Okay. The resistance can be on with the two of the regions, one is the primary and another is secondary. So we will see what is primary here. Primary resistance means it may be primary in untreated patient, that is they have acquired infection from patient harboring the resistance bacilli, means the person has taken a resistance bacilli. So that is the primary resistance. What is secondary resistance? Secondary resistance is developed inside the body. Yes. So secondary which develops during the therapy in an individual. So this is a basic difference between the primary and the secondary resistance which occur in the Depsone case. Yes. Now we will see the incidence of primary Depsone resistance. So what are the numbers? It is varied from 2.5 to 40%. Yes. Whereas if we will see the secondary, means which the resistance which developed during the therapy, it is accountable to the 20%. Yes. So chances of acquiring the resistance is higher in this category. We will see in the primary condition. Now see the pharmacokinetic. So how the absorption, distribution, metabolism and excretion of Depsone. So Depsone is completely absorbed. Yes. It is the penetration towards the cerebrospinal fluid is poor. Yes. 70% plasma protein binding. Yes. Acetylated and glucuronide reactions and sulfate conjugation reaction that occurs in the liver. Okay. So metabolism is by these three. Then metabolites are excreted in the bile. They are reabsorbed from the intestine area, so that ultimate excretion mostly occurs in urine. Now see other parameters. So T half, okay, half life is variable and often it is more than 24 hours. So it is retaining in the body for a longer time. Elimination 1 to 2 weeks or longer. Okay. Now it is available in the 25, 50 or 100 mg tablet. Now see the adverse effects when we need, we have not to give it to patient. So Depsone is generally well tolerated, nearly to 100 mg per day. What will happen in some of the patients? We have seen the lysis, hemolysis, okay, RBC lysis. So mild hemolytic anemia is common, especially on those patients who are suffering with a G6PD deficiency. Yes. So it is dose related toxicity which is we have seen in the patients of G6PD deficiency. Yes. Gastric intolerance is there. So there will be nausea, okay, feeling of vomiting and loss of appetite. Sometimes also we have seen there will be cutaneous reactions, skin reactions, okay, which is including the rashes over the cutaneous layer, or there will be eruption on those areas. So skin will be erupted, light allergy will be there, okay, and rarely exfoliative dermatitis, okay, there will be inflammation on this dermis layer and that will erupt, okay. So this is also one of the painful skin condition. Now contraindicated in the patients in which the hemoglobin is less than 7, because hemolytic anemia is common, okay. G6PD deficient patients, in those patients also there will be anemia. So, the drug is contraindicated. The person who are showing the hypersensitivity reaction, so we have to check on them. Now, for other uses means Depsone is given for the leprosy, as well as there are some other conditions like it is given for the malaria. Yes, in the combination with pyrimethamine, Depsone can be used for chloroquine resistance malaria when this drug is not effective. At the time this combination, pyrimethamine and Depsone combination can be prescribed. Another clopazine, this is a phenazine derivative, this is a dye. Yes, this dye has a leprostatic property. So, it can suppress the growth of lepra, yes, lepra bacteria. It has also the anti-inflammatory property, okay, which we are seeing means the inflammation is one of the common feature of the leprosy disease. So, we can use this drug due to this property. Now, it acts probably by interfering with the template function of the DNA. This is mechanism of action. Yes, when used alone, resistance to clopazine develops in 1 to 3 years. As this disease requires a long term therapy. So, we are prescribing the drugs in a combination so that the resistance will not occur. Yes, clopazine is orally active, oral tablets are there. It accumulates in many of the tissues, but the penetration to CSF is low or poor. T half is 70 days. So, it retains in the body for a longer time. Yes. What are the brand name? Clopazine, Hensepran. The another name for this leprosy is Hansen's disease. Yes. So, there is one another brand name is of this drug clopazine is Hensepran, 50 mg, 100 mg capsule. Now, see what are the adverse effects of this drug. First is skin. Okay. There will be reddish black discoloration of the skin area, especially the areas which are exposed. Okay. So, means there will be photosensitivity, phototoxicity reaction will occur, discoloration of the hair and body secretions, okay. Dryness of the skin area. So, mainly you can see it is affecting the skin, means the adverse drug reactions they are from the skin part. So, dryness of the skin or itching in the skin area. Conjunctival means there will be that particular part of the eye, conjunctiva, pigmentation may create cosmetic problem. Yes. What are the GI symptoms? Gastrointestinal symptoms. So, there will be inflammation in the intestine, enteritis, okay. There will be loose stools, nausea followed by abdominal pain, loss of appetite and weight gain, weight loss. Yes. Clopazine is to be avoided at early pregnancy. Yes, because we have seen there are some abnormalities with the baby. Yes, and in patients with liver and kidney damage. So, this is the precaution. Yes. Then rifampicine, this is the anti-tubercular drug which is prescribed in the treatment of leprosy. So, rifampicine is a bactericidal, means it will kill the bacterias, Mycobacterium leprae. How much it is effective? So, it will kill nearly 99.99% of Mycobacterium leprae in 3 to 7 days. So, this is very effective drug. Okay. It has been included in MDT as well, multi drug therapy. It should not be given in patients who are suffering with hepatic or renal dysfunction. Okay. Rifampicin congener means there are some other forms of rifampicin as well, like rifabutin. Okay. This also has the sedal activity, killing activity over this bacteria, but not superior to the rifampin. So, we can prescribe these drugs for the treatment of leprosy. Then another drug which is anti-tubercular is etheonamide. Yes, etheonamide drug also has antileprotic activity, but there are chances of liver damage. okay, hepatotoxicity in nearly 10% patients. How much dose it is given? So, 250 mg per day. What are the other antibiotics if we will see apart from the anti-tubercular drugs according to the clinical trial is ciprofloxacin. Okay. So, ciprofloxacin, it is not active against Mycobacterium leprae, but the another congener you will see ofloxacin, pfloxacin and getifloxacin, they are, or sparfloxacin, they are effective against this bacteria Mycobacterium leprae, and they are preferred to give in the leprosy treatment whenever the previous forms of drug, means the anti-tubercular drugs or the sulfone category drug, phenazine derivative drug, they are not effective. Now, we will start with the ofloxacin. So, ofloxacin, it hastens, it is fastening the bacteriological and clinical response. Okay. This is the clinical trial data. Nearly 99.9% bacilli were found to be killed in 22 daily doses of ofloxacin monotherapy. How much dose is effective? See, 400 mg per day. Now, we will see with the minocycline. So, minocycline drug, this is another antibiotic, it has a high lipophilicity, okay, means lipid loving drug. This tetracycline is active against, this is a tetracycline congener, minocycline, okay. It is active against Mycobacterium leprae. How much dose is required? So, nearly 100 mg per day produces a peak blood levels, which that exceeds the MIC, minimum inhibitory concentration. Okay. So, to inhibit the bacteria means how much quantity is required to inhibit the bacteria is known as MIC. So, it is required nearly 100 mg per day. Yes. Now, its antibacterial activity is much less than that of rifampicin. Therefore, on the initial level, if we will see the therapy of a patient, we are prescribing Depsone, rifampicin, yes, Clopazine. Then if after the treatment of the patients, if we are seeing in the reports or the patient is reported that the therapy is not effective, then we are seeing or preferring for the other options like other antibiotics, ofloxacin or minocycline, okay, sparfloxacin, getifloxacin, like these drugs. Now, claritomycin. See, claritomycin, it is only macrolide antibiotic with significant activity against Mycobacterium leprae. However, it is less bactericidal than rifampicin. Okay. So, first choice is rifampicin, then only if it is not effective, we can prefer clarithromycin. Monotherapy with clarithromycin means single drug. Monotherapy means we are prescribing a single drug. So, clarithromycin 500 mg daily, it is killing the bacteria nearly to 99.9%, but how much time it is taking? 8 weeks. Okay. It is being included in alternate MDT regimens. Okay, that is why I told you there is a one MDT regimen which is prescribed to all of the patients, but if it is not showing the effect, at the time we have some alternate MDT regimens. Now, see the treatment of leprosy. So, treatment of leprosy is done on the basis of which form of leprosy the patient has. Yes. So, there are two types of leprosy. One is paucibacillary, another is multibacillary. Yes. In the paucibacillary, microbial load is less comparatively to the multibacillary. Paucibacillary, the skin lesions are less. Yes, microbial load, which I told you, microbial load is also less. And nerve involvement, okay, because I told you nerves are involved in this disease, okay. So, nerve involvement means how much the nerve damage occur. So, the nerve involvement is also less in paucibacillary compared to the multibacillary. Now, if we know this paucibacillary is less severe comparatively to the multibacillary, so the treatment duration is also different. For paucibacillary, the treatment duration is for 6 months, whereas for multibacillary, the treatment duration is for 1 year. Yes. So, see the difference is here, paucibacillary and multibacillary. For paucibacillary, the skin lesion is less than 5. Okay. For multibacillary, skin lesions are more than 5, which I told you already. Now, so how will treat? Will prescribe the rifampicine 600 mg once in month. Yes. So, monthly 1 tablet is given, supervised plus Depsone 100 mg once in a day, OD, okay, say for 6 months. So, these two drugs are given for the treatment of paucibacillary. One is rifampicine and another is the Depsone. Rifampicine 1 tablet once in a 1 tablet per month. Yes. Depsone 1 tablet daily. Yes, up to, and this is up to 6 months. Then we will see the multibacillary. So, what is the treatment? We are giving rifampicine R 600 mg 1 tablet per month. Yes, and if we will see the second drug, clopazine is added here. Okay. So, we will give the clopazine drug 300 mg once monthly. So, we will write 1 tablet 1 month. Okay. They are of course under the supervision. So, Depsone, and Depsone is here, this is a very important drug. Depsone will prescribe 100 mg OD. Okay. So, we will give 1 tablet once in a day, daily, and clopazimine 50 mg. So, dose is different. You can see the first clopazimine which is given monthly is 300 mg, and there is another clopazimine formulation we have prescribed here is the 50 mg. So, this is given for daily basis, once daily. Okay. And for how much duration it is? It is for 1 year, 12 months. Yes. So, this is the combination which is prescribed for the treatment of multibacillary. Here the doses, we can see how the doses are varying. Okay. So, I hope this is clear to all of you about the treatment of the leprosy, what are the different kinds of leprosy, okay, what are the data related with the leprosy. So, we will just do a little recap on it. What we have discussed today is the, yes, with the leprosy which is caused by the Mycobacterium leprae, and then we have discussed about these 4 drugs, these 4 classes like sulfones, phenazine, derivatives, antitubercular drugs and some other antibiotics. Yes. Then we have discussed about the mechanism of action of Depsone. Okay. Then what are the adverse drug reactions? So, most of the adverse drug reactions are related with the skin. Yes. Either it is a Depsone or it is clopazimine. Then we have also considered some miscellaneous drugs which is including the some antibiotics like minocycline, claritomycin, yes, ofloxacin. These drugs we can give at the time when there is a resistance with the primary drugs. Okay. And in the treatment of leprosy, there are 2 forms like paucibacillary and the multibacillary. Depending on the microbial load, we have changed the duration of the therapy. I hope this is clear to all of you. Thank you so much everyone. We will meet in the next session.